Good morning. I'm going to record this class. Before we start, how was the exam?
Wonderful. Horrible.
Very good.
We let out all of our frustrations during special cops.
Okay.
I couldn't have thought of any other better question.
Good.
There's no bonus points.
He's speaking for himself.
Okay, just to calm your anxiety, we're gonna meet this afternoon and review the test. So I just want you to know that we have not reviewed the test, so we will do that. But if I hear any more thing about diarrhea anymore, I'm gonna kill somebody. Everybody has been texting me about diarrhea, the previous class about diarrhea. So I just want you to know we have not looked at the test, so we do that this afternoon. So that please, you can calm down and focus on the next exam, right?
Yes.
Yeah, because we can't change the past, but we can change the future. So let's make sure, remember, we still have to take exam on this class. So calm that anxiety down and let's focus on what we have today. Okay, what are this? Which exemplar do we have today? Osteoarthritis, what else? Osteoporosis. Okay, today we will focus on osteoporosis, osteoarthritis, and herniated disc. So which concept do we have today? Mobility. Like every other concept, we need to start with the SLO because the SLO guides the class. It is important we pay attention to this SLO because that's why we say the test. That's what guides our, organizes the class for us, guides the objective of the class, guides the explanation we do, guides the test we give. By the end of this class, mobility, the student will be able to interpret assessment data. Again, assessment data, numbers or things that are objective. You need to be able to explain to the patient. Remember when we did the safety, the S stands for system specific. When those patients go for a test and come back to you, what will you do for the patient? So that you don't mess up the surgery or test that they went to. You need to be able to analyze data. Numbers becomes important. Like I told you, every exam you have to have dosage calculation for a reason. Because we are training you to be nurses, every nurse gives medication. You have to be able to know what you're doing. You have to be able to know how to give this patient medication and the doses. You need to be able to prioritize patient actual or potential problems. Patients that have mobility issue, they have pain. On the average, they all have pain. When they come to you, what will you do first? How do you prioritize what you do for them? What will you do first to resolve the current problem they present to you? And what will you do to prevent them from having more complications? So if they have mobility issue, they come to you. What are you going to do for them so that they don't go and become debilitated in the bed? They don't get up anymore. So in between all that, what will you do? Prioritize that care. What will you do first before you do second, third, and fourth? By the end of this class, mobility, you'll be able to create measurable and achievable short and long-term goals. 2 and 3 kind of resemble each other. Short-term goal, the patient has to be able to get out of the bed and ambulate because ambulation is one of the normal things that everybody's supposed to be doing. You need to be ambulating to go to the kitchen to cook your food. You get up, go to the refrigerator to get your food. You get up, go to the bathroom to pee. So ambulation becomes our goal. If that patient cannot ambulate, what is the short-term goal? So what is the priority intervention that we need to intervene so that this patient will be able to start moving around to prevent long-term complications? By the end of this class, again, mobility in general, you'll be able to analyze concepts and examples based on nursing collaborative intervention. You are not going to do all this by yourself. Patients that have mobility issues, you have to collaborate with physical therapy. You have to collaborate with nutritionists and see what kind of diet they can have. You have to collaborate with physical therapy to get them up and ambulating. You have to collaborate with CNA to measure accurate intake and output. So you cannot do this by yourself. Your ability, I always say that your ability to be able to know the right resources to help your patient is also an intervention. If a patient is having difficulty getting out of bed, you're not going to call respiratory therapists. Your ability to know that you need to call physical therapists, as far as I'm concerned, is an intervention. Call the right people for the right problem that the patient have need for, to be able to help the patient feel better. By the end of this mobility, you should be able to evaluate expected patient responses, progression or not so progression. It's not always that we intervene that everything we do works. If it doesn't work, what will you do next? Sometimes we ask those questions, we put it in the stem of the question. Patient has S, Y, and Z. The nurse did S, Y, and Z. What will you do next? If you do something that is not working, you intervene, it's not working. Patients that have mobility issue, have different complications. You don't want them to have deep vein thrombosis, but if they do, what will you do first? They have pain, what will you do first? Or what will you even do to prevent any of this from happening? We're going to talk about all that today. So evaluate those responses. When you intervene, it's not working. What will you do next? That means every time you do intervention, you don't ever assume that it's working. You have to go back and reevaluate your intervention to make sure it's working. So that's the SLA that will guide the class today. Mobility. What comes to your mind when you hear the word mobility? Anybody? Movement, walking, movement. Joints, muscles. What else? Somebody is saying something else. Falling. Hopefully we don't get there, but falling. Gait. Range of motion. These are what comes to you when you think about mobility. Mobility is ability to move. Mobility becomes one of the basic human needs. We have to get up and move. We can't do our activity of daily living if we are not moving. We are not going to be able to even go to the bathroom if we are not moving. You can't go to the kitchen, get your food, refrigerator, get your food if you are not moving. Mobility also becomes one of those things that help a patient or an individual for improve their well-being, to feel better, reduce stress, feel good. You have to be able to move, to do things. When you are not able to move, you are hindered from moving. That creates a lot of problems for the patient and for anybody. So looking at the overview of mobility, there are so many things that causes patients not to be able to move or have difficulty moving. One of them is age. So what else? What else do you think contributes or prevents people from moving? Illness. What else? Trauma. What else?
Weight.
Fracture. Weight. What else? Depression. What else? Injury. Well, trauma. Trauma becomes injury. Medication. What else? So, these are most of the things that actually will prevent people from moving. If they are sick, or they have fracture, or they fall down, or they have illnesses that will limit them from being able to move from one end to the another, or they have medication. Sometimes when you give a patient, especially elderly, when you give a patient narcotics, will they be able to get up right away and move? No, it becomes a safety hazard. So when you give them pain medicine, you don't want them to ambulate right away because they might be easy. That's one of those things I hate when physical therapist comes to get the patient up to walk. They always say, oh, who has the patient in 7221? I'm like, me. Can you give the patient pain medicine? I'm about to walk the patient. I'm like, really? Okay, you right there standing, waiting for me to give the patient pain medicine. Okay, I'm giving the patient pain medicine. It is PO, Percocet, or oxycodone. You waiting. Then the next thing I know, you're standing the patient up. Has the medicine kicked in? No. First of all, it's not going to relieve the patient pain. It might kick in when you're already ambulating, doing something. Then you wonder why the patient is easy. They not want to walk anymore. You tell the patient they are lazy. They don't want to do anything. No, you give them something that's going to make them feel like that. It's always good to call ahead of time. Give the patient pain medicine. Let the medicines come to the point where patient won't be too drowsy yet. So we need to watch for that. So when our patients have trauma, when they have trauma, especially in New Orleans here, gunshot wound every day. Our patient falls in the street here. The street here is never even. So if you're walking, please put your cell phone in your pocket. You're going to fall because you're going to trip. You're going to trip. Because actually, it happened to me in the front of the school right here. Our old coordinator texted me something. It was so bulky, I couldn't read it. Somebody said, oh, go outside the building. So, of course, I'm going outside the building. It's still spinning. I'm doing this. I'm like, how far will I go before it stops? In front of the school right here, before Perdido, just in front, there was an even space. I fell. And then being AARP, I have to go to the doctor. Because I don't want to hear nothing 20 years from now. Did you fall one time? I'm like, really? So, but there was no broken bone anyway. But uneven surfaces is high risk for fall. That's where I'm heading with that. So, watch for that. Weight. Too much weight puts a lot of pressure in the joint area. So, patient needs to lose weight. Depression, especially when they have severe pain from having those joint problems, they're not going to want to do anything. Those patients get depressed. So we need to educate them. Some medication that causes osteoporosis is also high risk for fall, can contribute to the patient having issue with mobility, like steroids. Okay. Those patients that have mobility issue, what are those signs? How do you think we can treat that? What is your own intervention for that? You can put them on immobilizer. What is immobilizer? What is to immobilize something? To immobilize means what? To keep it from moving. Most often when they have those joint pain, we use immobilizer either in the arm to kind of stop that area from moving, prevent pain from that. Those patients can use assistive devices. What are examples of assistive device? Walker, crutches. You all did that in level 1, right? Huh? Okay, I was about to say whether one class did it and the other did, because I ask the same question every time. So, yes, those assistive devices like walker, wheelchair, crutches, they can use that to supplement from the pain they are having. What else? What else do you think we need to do for them? Give them pain medication. NSAID. What is NSAID? Non-steroidal anti-inflammatory drugs. When I asked that in the previous class, only one person knows what I'm talking about. We use a lot of abbreviation that we abbreviate ourselves to death. And we don't even know what they mean. We just use that. So non-steroid anti-inflammatory medication becomes one of the most common medicines that we give those patients that have mobility issues. Aleve is one of them. Aleve is a non-steroid anti-inflammatory, or naproxen, or the most common one we use in the hospital is what? Ibuprofen or Motrin. Those are non-steroid anti-inflammatory. medication. So we need to educate the patient on this non-steroid anti-inflammatory medicine. So what will you teach them on how to take it? They have to take it with food. Why? Irritates the GI, right? So they have to take those non-steroid anti-inflammatory with food because it irritates the GI. Because it's the most common medicine they use for mobility, patients that have joint problems because of inflammatory responses. You need to educate them on how to use it. What other thing do you think you look for? Patients that have non-steroid anti-inflammatory. What does it cause besides GI upset? Huh? I can't hear you. Hepatotoxicity, yes. Yeah. But I'm looking for bleeding. Bleeding becomes another thing that you need to educate the patient. Most of these patients, because of these chronic illnesses they have with joint deformity, because it catches up with them like mostly elderly patients, they take this non-steroid anti-inflammatory for a long time. Educate them, it can cause bleeding. These are the patients, if they go into surgery, you have to stop that non-steroid anti-inflammatory because of that high risk for bleeding. These are the patients that you need to educate. If their bowel becomes dark, they need to report it to the nurse. What is bowel that's dark called? What is it called? Your stool that's dark stool? Melena. They need to notify the nurse for melena. Educate them that the blood might not be bright red, it might be dark stool. So educate them on that. Because of that long use of non-steroid anti-inflammatory, they need to be educated. Another medication is Tylenol, acetaminophen. It's mostly the most common used one. What does Tylenol do? Pain. It's also antipyretic. Huh? Okay. Huh? Fever, antipyretic. So, what do you think we need to educate the patient that's taking Tylenol? You just said it earlier. Liver toxicity. Liver. Because Tylenol is metabolized in the liver, it can also cause liver damage. That's why we have increased in cirrhosis of the liver in the community now. To me, even though I haven't read it in research, but with the experience, I kind of know that because of this increase in opioid use and increase in cirrhosis of the liver, they go hand in hand. Why? Because most of those pain medicine that they use has a lot of Tylenol. But people don't pay attention to the Tylenol aspect of it. They just take the pain medicine. So now we're having problem with cirrhosis of the liver a lot. I'm beginning to see that compared to before Katrina now. A lot of cirrhosis of the liver. Before, you can go a whole year, you don't see a patient with cirrhosis of the liver. Now, if I don't see a cirrhosis of the liver a week, it must be Christmas week. So there's increase because of Tylenol. So we need to educate them. And then again, before, we used to say, take Tylenol 1 gram every 6 hours, no more than 4 grams. But now, it's 1 gram every 8 hours. 1,000 milligrams or 1 gram, Q8 hours. So no more than 3 what? Grams Q day. So you need to educate them that. No more than 3 grams a day, 1,000 milligrams every 8 hours, no more 6 hours. Like no more 1,000 every 6. So now they reduce the standard because people were overusing this Tylenol. And to be honest with you, it's working. They're not giving patients narcotics a lot like they used to. And it's working. I have seen patients that have surgery 2 days, they're getting Tylenol 1 gram, and it works. I'm like, where have we been with this? So it's all about tweaking the brain. Some of these things are just mental. It's working for them. Some of them might have Ultra to go with it too, but they get Tylenol. So medication, you mobilize the area, give them assistive devices, give them medication. Then heat or cold. Heat or cold? What does heat do? What does heat do? It's a vasodilator. What does cold do? Vasoconstriction. So it is very soothing for those patients. When you apply heat, it makes the area kind of soothing for them. It makes blood flow to the area, brings nutrients, brings oxygen, helps with that pain they're having in their joint. When you apply cold, it makes it numb. They don't feel anything. That's soothing. But you don't want to do each for a long period of time. You want to alternate heat and cold. You don't want to vasoconstrict with cold all the time because that prevents blood from getting to the area, the joint area. You don't want to put heat all the time either. So alternate heat and cold. I think the rule of thumb is like 15 to 20 minutes heat and cold. Alternate that because you don't want to do one too long.
So wait, so 15 minutes you put heat and then for 15 minutes you put cold.
Mm-hmm.
Okay.
15.
And it can be back to back, like right after you
I
apply.
probably will wait. I wait in between. I wait like 10 minutes or 15 minutes. Cold, 10 or 15 minutes. Heat. Just alternate them each for 15 minutes. Don't let it stay all day before you alternate. Because it's soothing for the patient, they may say, oh, don't take it off. Oh, just leave it. I like it. But explain to them the rationale behind what you do. They have to know the rationale or they won't comply. When everything else fails, surgery. Surgery becomes like the last resort. When these patients have taken pain medicine for a long period of time, and then they have, you have immobilized the area, you have done exercise. Exercise is another thing you do. Exercise, especially with physical therapy, helps also with those joint pain. Physical therapists know how to do that, to make sure the patient uses the muscle they're not using. It helps them out to strengthen those areas and reduce pain. So exercise, surgery is the last resort. Okay, this information is general for anybody that have mobility issue. Remember, patient can come in the hospital with brain surgery, they're going to have mobility issue. Patient can come to the hospital with COPD, they're going to have mobility issue. Patient that can come to the hospital with back pain, they're going to have mobility issue. It's not just those exemplars we discussed today. It could be any patient. That brings me again, when we're talking about medication for those patients, what medication do you give every patient that's in the hospital to prevent them from deep vein thrombosis? Any patient. Lovenox. We have talked about aspirin. Lovenox or enoxaparin. Sub-Q. What else? Heparin. Sub-Q. What about aspirin? What other medicine do we give anybody in the hospital to prevent them from having constipation? Docosate sodium, right? Coles. Everybody takes Coles. I should have have a franchise with Coles people. I should be a millionaire by now. Everybody takes Coles. So, if you notice, Lovenox and heparin, to prevent them from having blood clots. You're covering perfusion aspect of the problem they're going to have for being immobile in the bed. Because if they are not moving, blood pulls to the lower extremities, predisposing the patient to what? Deep vein thrombosis that can dislodge, get to the lung, causing what? Pulmonary embolism. You see how perfusion, mobility, immobility, and oxygenation go hand in hand. That's why we give everybody Lovenox. Even if you look at that MAR I gave you when we were doing oxygenation, they all have Lovenox order, even though they have respiratory issue. But they're not moving. As long as you are immobile in the bed, you belong in this category of mobility problems. So you give them Lovenox sub-Q, heparin sub-Q. No lab values are necessary. No lab. You don't have to do PT, PTT, because it's 5,000 units sub-Q. It's not like you're doing it IV, heparin. So you don't need to do lab values to check their level. You just give it to them as the doctor ordered. Of course, aspirin, again, you have to watch bleeding. You have to educate those patients. If there's any bleeding or melena, they need to let us know too. Coles covers GI. Those patients, they're not going to be able to have bowel movement because they're immobile in the bed. They're going to get constipated, so we give them stool softener, Coles, for that. Okay. Herniated disc. What is herniated disc? Anybody? What is the most common name for herniated disc? What is herniated disc? Okay. What does the word hernia means to you? Bulging. Something that's bulging. L4, L5. Herniated disc is back pain. Another name for it is back pain. For a patient to have problem with back pain, what do you think are the contributing factors for that? What do you think is What do you think is contributing for them to have this back pain? Weight, inflammation, weight, inflammation, poor posture. Huh? Job. Poor body mechanics. Alcohol intake. That's what they say. Poor body mechanics. What is body mechanics? Okay. Okay. So, if we have this box is full and it's on the floor, how do I pick it up? Anybody? Anybody? Anybody can come show us how to pick up this.
The right way or the wrong way?
What do you think? Did he do it right? Yes. Very good. Thank you. Let's clap for John. Thank you.
He just left it on the floor.
Why did you put it on the floor? You want me to bend? That's okay. I'm just joking. So you bend down, use your knee muscle, and put it up. Don't ever bend your back, because when you bend in your back, you're straining what? Your lumbar. You're straining your back. And when we're looking at the back, we're looking at the L4, L5, which is down here. L4, L5. That's usually where you have the back problems. When you're lifting, use your leg muscles. How many of you have seen the policemen? You can never see the police people standing with their two legs like this. They're always like this. They stagger and do this. What does that mean to you? Balance. It's all about balance and posture. If you push a policeman this way, when they push you, you're going to hit here. You're going to go to the next room. But if your legs are together like this, if you tap that policeman, you'll be on the floor. So you can never see a policeman with their two legs together. They're always like this. That's a good posture that you push them. When they push you outside that window, still standing. Pay attention to that from now on. You can never see them, their legs together, because you can easily fall if they tap you. It's all about body alignment and posture. You have to always align your body when you're doing things. Otherwise, you're going to increase that problem with your back and causing back pain. When a patient has back pain, this is the vertebrae, this is the vertebrae. There's something here they call the porpulus. Porpulus. When they're having back pain, this porpulus is herniated. Herniated means what? Protrusion, right? It is protruding outside its area and protruding out here. Remember, I always say, anytime you have any part of the body encroaching where they don't belong, they're going to cause pain. So, this protrusion here creates pain because now it's touching on the nerves adjacent nerves of the body, creating back pain for the patient. And when those patients have pain, they're going to say, oh, my leg hurts. The pain radiates from the back to the hips, to the legs, to the lower extremities. How many of you know somebody who have back pain? Or you yourself have back pain? Marilyn, do you have back pain or you know somebody? Okay, so tell us about what you have. Okay. You raise your hand.
Well, I play volleyball a lot.
Talk to them so they can hear.
I play volleyball from the 3rd grade to the 12th grade, so a lot of rolling, stuff like that. I strained my back before, ever since I've been having back.
Twisting is part of the problem. Twisting. See all those rich men, when they play golf, I just be looking at them. I'm looking at back pain. I'm not even looking at the golf. They're doing this. Do you realize how much pressure you're putting on your lower back? So I be like, I know you have money. Make sure you save all that money for your back surgery. That's the only thing that comes to my head when they do. Each time they hit the ball, that's all I'm thinking. It's bad to think like that. I should be enjoying the game, but that's that's the only thing that comes to my head. So twisting is also poor body mechanics. So you have to be able to avoid twisting if you can. In the case of baseball, I don't know if there's, not baseball, golf, I don't know if there's any other way to do it, but at least wear something to stabilize your back when you do that. So twisting is part of what contributes to herniated disc. So once it's pressing on those nerves, the patient has pain. The pain radiates. It's not unusual. The patient I took care of last week that had back surgery, she said, oh, my leg is numb. I always feel it all the way to my leg because of that sciatica pain. The nerves, the protrusion, pressing on the nerves, creating that numbness or tingling in their lower extremities. Huh?
I pinched the nerve before.
Okay. I don't know. Lord help us. That's all I can say with her. So when a patient have herniated disc, you give them those non-steroid anti-inflammatory, you give them pain medicine, exercise, use assistive devices, use immobilizer. These are your interventions. If none of this works, the next thing becomes surgery. Surgery is usually the last resort of anything. Doctors don't really rush to surgery unless every other thing is not working. So when they have this surgery, there are so many types of surgeries. But we're going to focus on the most common one I see all the time in the hospital, laminectomy. Laminectomy. What is to laminate something? When you're laminating your paper, what you doing? To laminate, what does that mean? Okay. But what is the act of laminating means? Sealing something up, right? You're not just protecting it, you're sealing it up together. You're putting two things together. Yes. That's not true. They have improved a lot. In the 90s, yes. If I have anybody that was about to do back surgery, I would say, please, ma'am, get second opinion. That was in the 90s. Now, they're doing much better. I have seen people really improve from that. In the previous class, one of the ladies said she had surgery 12 years ago, and she's pain-free. Patients are really improving. I don't know what it was, but before, nobody gets pain-free. Actually, they ask for more pain medicine after the surgery than ever.
They finally figure it out.
They
finally figure it out.
Maybe they finally figure it out, but now it's working much better. Actually, the doctor at Tulane that gave me and my clinical group, talk to them about what the doctor told them.
The doctor that does the laminectomies came in and spoke with us, and I asked him about that, and he said most patients that he does surgery on are at a pain
quality of life. Mhm. So, I mean,
I just was saying because when I see people who come into my before I let them on laminectomy or whatever, sometimes I crave because I'm like, they gonna come in, they still gonna be in pain. You know, most of the time when I see people, they're like at a 9,
mm-hmm, mm-hmm.
and they're extra all the pain, like, they come back in, still at 8.
So did they just have the surgery, or they had the surgery a long time? Okay. Okay, John. That's why surgery is the last resort. Surgery is always the last resort. But those patients, I mean, is better than the type of pain they had before. We have this new doctor at Tulane that's new, trying to perform new neurosurgical surgery like laminectomy. So he has something very rigid. So he was educating all the nurses at Tulane. So I told him, can he please talk to my clinical group? And he did. He took time, talked to my Wednesday group and talked to my Thursday group. It's all about mobility. To him, it's all about getting the patient out of bed right after surgery. It's all about watching their bladder, just what we're going to be talking about. Watching their bladder, make sure they urinate. Give them the pain medicine, make sure they start ambulating. He will perform the surgery in the patient. By that night, the patient is out of bed in the chair. That's a big improvement. It's all about ambulation. Because once you get out of bed to chair, you're reducing the complication of immobility while you're in the bed. So I like his style because he's very aggressive with that. And I'm seeing improvement. I'm seeing improvement with those patients. So, but anyway, it is the same principle. Laminectomy, to laminate. Laminectomy, when those patients have a protrusion of those populus, it touches outside, causing pain. So what the doctors do, they go in there, remove some vertebrae off the back, and then replace it with screws, and God knows what they do with that. When the patient comes back to us, they're going to have incision in their L4, L5. That doctor is even saying they're using robotic. They're doing robotic surgery now, whereby they don't have big incision anymore. They have small incision with robot. You always know that the lesser the incision, the better recovery. Because now you don't have too much scars, you don't have too much open area to deal with. So they're doing much better. So when this patient comes back to us post-operatively, is it different from any post-op that you know of? What do you think you need to watch for? Patient that have back surgery comes back to you on the med-surg floor. Swelling. What do you think you need to do for the patient? Okay, you assess the wound site, right? Okay, so what else? Now I've given you the clue. What else? Watch for infection. What else? Watch for bleeding. Infection, bleeding. Get
like the numbness and stuff.
Yes. Out of bed to chair, at least. Numbness. Where you do the pulses. Dorsiflexing. Dorsiflex the toes. Okay, so when they come to you, you have to assess their wound. As you're assessing the wound, you're looking to see if there's any leakage in the wound. So if they have white fluid leaking, that might be cerebrospinal fluid. If it's white and it's clear, cerebrospinal fluid. At any time you have CSF fluid leaking out of an incision, it is a medical emergency. We have to notify the doctor, because that means now not only that the fluid is leaking, there is a hole where it's leaking out from, and you don't ever want any spinal area to have a hole into it. That's going to create infection for the patient, and when they have infection, it's going to be systematic, and the patient will be very sick. So if you have cerebrospinal fluid leaking, you need to notify the doctor. So if it's clear white, notify the doctor. If it's red or serosanguinous fluid, if it's red or it's serosanguinous fluid. What do you think you need to do? You're recharging a battery? A patient with laminectomy comes to you. The patient has serosanguinous drainage in the incision site. What will you do first? A, call the doctor. B, reinforce the dressing. C, reposition the patient. D, call the CNA to assist you. I know that's what you're thinking. Reinforce the dressing. Why do you reinforce the dressing and don't call the doctor? It is normal. It's the first post-op dressing. Remember, only the doctors can remove the first post-op dressing. Because you were in there, you don't know what they did underneath. So the doctors put it in, they have to take it out. They did the same thing you did when you did peri-op, and the same principle. A patient that have lumbar fusion comes to you 3 days post-op. The patient incision is saturated with clear white fluid. What will you do first? A, call the doctor. B, reinforce the dressing. D, call respiratory therapist. D, reposition the patient. What will you do first? Why? Okay, very good. You see how that goes? Because it's white.
If you were to reinforce that, though, would you also help the patient losing more?
With what? Remember, the question says, what will you do first?
Yeah, so it'll take time to call the doctor, but wouldn't reinforce?
It's not going to take time to call the doctor. No. Remember.
You have a phone in your pocket. Trying to what he's getting at. Wouldn't you reinforce the dressing to protect it from infection?
Okay.
It's already been 3 days.
Can I clean this here? Maybe up here. Maybe up here. A, patient has patient has clear fluid. We don't know what it is. We just say clear fluid, right? Clear fluid. What will you do first? A, call the doctor. Call the doctor. B, reinforce dressing. C, reposition patient. D, call CNA to assist you. So you're saying you need to reinforce. What will you do what? First, remember, anytime the question asks you, what will you do first? You could have done any of those. You remember this? You diagnose the cues, the layers of clinical judgment. You diagnose the cues, you analyze the cues, you prioritize your hypothesis. These are the priority hypotheses. So you generate solution. What are you generating the solution for? When you're generating the solution, you're looking at to see what outcome are you expecting to see. What outcome are you expecting to see that the patient that have clear fluid? The outcome you're expecting to see is that you don't see the clear fluid leaking, right? And you cannot fix that. So you take action. The action you're going to take is called the doctor, because you cannot fix the leakage. And it's life-threatening situation for the patient. So you call the doctor, then you reinforce. While you're waiting for the doctor to come, you reinforce. You might reposition the patient. You might call the CNA to come help you to reposition the patient. So anytime you have, what do we do? Then you evaluate your outcome. You have to call the doctor to do this. If you're taking action by just reinforcing it, you still have not resolved the problem, because you cannot fix that. Because it's leaking cerebrospinal fluid from the surgery. You cannot perform surgery. So you have to reevaluate your intervention. You have to call the doctor to come. While the doctor is coming, you call the doctor. You can be reinforcing it. Changing their sheets if it's saturated, doing all that. Then the doctor will come and say, this patient needs to be transferred for surgery, so they can seal it. Or if they want to do it at the bedside, depending. Because sometimes they do blood patch. I don't know. Whatever they want to do, they can either do it at the bedside or surgery after their own assessment. Yes. It can. In that way, you're assessing for swellings. They can have headache. Do you have a baby? Yeah. She's talking about epidural headache. Epidural headache is this. Most patients, when they're having a baby, they give them epidural through the back. When they give you the epidural, sometimes it leaks inside, just like she asked me. It can be leaking inside, and it's going to make the patient have severe headache. Why? The brain floats in the skull. So when you lie down, the brain flows away from the spine. You don't feel the headache. So once you get up, the brain sinks and presses in that fluid that's leaking, because there's no space in the brain. So that cerebrospinal fluid is in between the skull and the spine. So it presses on it, giving you severe headache. That's why you ask those patients, do you have the headache when you're lying down or when you're standing up? Once they say, oh, it's very severe when I get up, it's classic sign of epidural leaking inside. If they have it on both sides, well, then it's not that. So that's why you hear it. OB. All right. So do we understand this? This is what how the student gets confused in the test. What will you do first? All the answers have to be correct. But in what order? Priority. Prioritize the hypothesis. How do you prioritize it? You're telling me now the patient has clear fluid. Okay. Your goal is to make sure that that clear fluid don't come out anymore. You cannot fix it. So out of this, what will you do? When you prioritize your actions, what will you do first? You call the doctor, because he's the only one that can fix the fluid from leaking. If you put bandage, cover, reinforce the dressing, you just bandaging the problem. It's still going to be leaking, right? Do we understand that? All right. Okay, get the patient out of bed. You can get physical therapy. Another intervention, get the patient out of bed. You can get physical therapy to help you get the patient out of bed. These patients that have surgery will be in pain. So give them the pain medicine before they get out of bed. Wait for some time, then physical therapy can come help them. Numbness and pulses and dorsiflexion, tell them dorsiflex their feet, see if they have numbness. It's okay to have numbness, but I will still report it to the doctor, because they come to the hospital with that numbness anyway. But report it to the doctor so that to make sure it's not aggravated by the surgery that they have. Because one of the major problems with laminectomy or back surgery is nerve damage. Nerve damage becomes a problem in those surgeries. So, assess their bladder. Accurate intake and output. One of the major complications of laminectomy is urinary retention. Remember, back pain is L3, L4, lumbar here. Because it's lumbar here, there is possibility that the nerve damage in this area, so all the organs in this area might be affected because of nerve damage. So when they have this laminectomy, they come to you. You have to assess their bladder. So before I go further into that, tell me what you have learned so far, these two lines here. What have you learned so far? I've been talking for like 45 minutes. Tell me what you have learned so far about mobility on this side. Using proper body mechanics decreases the injury. These two lines, what have you learned so far? Alcohol is a risk factor. What else? Let's talk about patient stuff.
That doesn't matter what the actual problem is. Most of the priorities, most of the interventions will be the same. Payments, walking patient, ambulating patient.
No matter what their specific problem is, most of them will have the same problem. Pain medicine, walk the patient. Okay. What about these three lines here? What have you learned so far? Let's put it on the patient here. Let's talk about patient. We rotate hot and cold for pain. Okay. What else? Anybody? Laminectomy, you need to watch for urinary retention. Anybody?
Clear white fluid, call the doctor.
If it's clear white fluid, call the doctor because it might be what?
CSF fluid.
Cerebrospinal fluid, and it's a medical emergency. So bladder, because of that damage to the, possibility of damage to the adjacent organs, bladder is the most common one affected. There's another patient who took care of that patient on 70s that have the back surgery. We have to catheterize. Not everybody raise their hand at the same time. Okay, tell us what happened and what you did. Mm-hmm. Yeah.
He was working out. He hit a locker, ran into a locker, and he fell. Remember, that's what he said. He said he ran into a locker, he fell, had a back injury, woke up, and he fell.
Okay. So what kind of surgery did he have?
He got the surgery with Dr. But he had the one with the robotics.
He had what? The patient had laminectomy. So tell us what you did with the bladder. We haven't got into the bladder yet.
We did the bladder scan.
Why? Tell them why.
He was retaining a lot of urine. He had like 600 milliliters or something like that. And he was only letting us take it out twice. And he was supposed to be letting us take it out more. So he kept retaining a lot of urine. I had to keep going in and out.
She's a poor historian. Yes, you did good. You did good. Huh? Neurogenic. Neurogenic bladder. Neurogenic bladder. So, this particular patient, which is similar to the same patient, laminectomy, he was having issue voiding. The doctor said, do in and out, bladder scan the patient every 6 hours. If the patient have not peed, to do in and out cath. So, what is in and out cath? You put the catheter in, drain the urine, and you take it out. That's in and out. Okay. So he wasn't voiding. So if you have a patient that have laminectomy, you have to watch them closely, because they might be having urinary retention. Watch them for at least 6 hours. If they're not voiding, so like we did or she did, bladder scan them first. Bladder scan to see how much urine they're having. In this particular patient, it was 600. I know, it was almost 700. We need to do the in and out. He refused. We have to beg him and come up with all the rationale, because if they're not voiding, what do you think is going to happen to them? Anybody? UTI. They're going to have UTI. They're going to have infection. Not only UTI, if they don't void, they're returning urine. It's good. Very good. You remember good. Eh? So, if they don't void, the urine bladder is going to be full. It's going to start backing up to the kidney, causing kidney infection. So, just like when you all did prostate, right? You talked about this. Urinary retention is urinary retention, whether they have surgery for it or urinary retention from prostate enlargement. Is the same principle. Urine stays. Anytime you have stasis of urine, it's not being peed out. That's high risk for UTI. It's going to have kidney infection too. So they need to be able to void. So for this patient, he wasn't voiding. So we did bladder scan. It was about 700. So we went and did in and out. Sometimes this bladder scanner gives you like estimate. Sometimes it doesn't give you accurate. Sometimes the bladder scan, it might say 600. When you do in and out, it might be 900. So sometimes it just kind of gives you an idea. So first in bladder scan the patient, in and out the patient. Then wait another 6 to 7 hours. They need to be able to void. If those patients don't void, anywhere between 6 to 8 hours, we need to catheterize them. We need to drain that urine out. because they're not going to feel the urge to urinate. They're going to have neurogenic bladder. So it's not all those contraction and relaxation for them to pee is lost from the nerve damage related to the surgery. And doctor needs to know about that too. Any questions? Yes.
So after the person has the laminectomy, the first thing if you're going to the patient room post out, the first thing you want to do is check the bladder.
No. No. She said, well, she asked me, after the patient did laminectomy, the first thing you do is to check the bladder. One of the major problems the student have, they want what you do first all the time. What you do first depends on what's going on with the patient. If I have this patient that have laminectomy and I walked in the room, I'm going to check the airway first. That's what I'm going to do first. If the patient is talking to me and the O2 site is good, I'm going to start from there. The airway is good, he's talking, he doesn't have short of breath. I'm going to log roll the patient. That's another thing we do. When patients have laminectomy, you log roll them. That means the upper and lower extremity are turned at the same time. You turn the upper and lower at the same time. Why do you think we do that? Prevent injury and align the body. We're talking about posture and body alignment. Align the body so it doesn't dislodge from the surgery. Upper and lower, always get somebody to help you with that. So it's called log roll, upper and lower extremity turned at the same time. I'm going to assess the wound. I'm going to make sure it's not draining. If it's draining, I will assess the color of the drainage. I'm going to work my way down. I'm going to say, do you feel this? Do you feel me touching you? I'm going to say, does it flex your feet? He will do it himself. Do you feel me here? Yes. Here, no. Here, yes. Here, no. I'm going to start from the head and work my way down because I'm doing my assessment. Now, if the patient calls me or something is going on with the patient, I start out with where the need is. If the patient calls me and says, I can pee, I'm not going to start from the head and all the toes. It becomes focused assessment because now you're telling me you can pee. I go straight to the bladder. Actually, when you call me you can pee, I'm going to drag my bladder scan with me to see why you can pee. I'm going to bladder scan you. Then that tells me where you are with that. Compared to the number of hours you haven't peed, I will integrate all that together. You have to recognize the cue. The patient is going to tell you most of the things that the problem is. Once you recognize that cue, you analyze it. What is causing the patient not to pee? How long ago was that? If you had peed 2 hours ago and you're telling me you can't pee, I'm not going to worry about that. I'm come and assess you, but I'm not going to worry too much because you just peed adequate urine 2 hours ago. You're going to have all kinds of sensation when you have surgery. But I'll still come and assess you, press on your bladder. If you're not flinching, well, 2 hours is not enough for you to make urine. So you prioritize those things. Look at it. So your priority depends on the presentation of what's happening. Do I answer your question? Okay. Yes.
So you just had a laminectomy, and then did you offer like even a urinal, and you just can't produce urine?
You can offer them urinal.
Like for this specific patient, like he just can't.
He doesn't feel. He doesn't have the urge. He doesn't have the feeling. From neurogenic bladder, you're not going to have the urge and feeling. You don't feel it, period. There is damage to the neuron that's connecting to the bladder. You don't feel that urge that you need to pee. If you're feeling the urge that you need to pee, then you can pee. I can offer you urine and say try. But if you're not feeling even the urge to even pee, urine is not going to do us any good at this time because you have surgery. I know what is possible causing that. But the patient will still be retrained, though, to be using the urinal. You don't want to depend on in and out for life. They still be training to be using their urinal. But right now, I'm going to kind of help you out.
This patient is not able to just get out of bed by himself.
No.
Yeah. Okay.
Right.
Bed rest or up with assist?
Huh?
He'll be up with assist or bed rest?
Yeah. He'll be up with assist a couple of days. Now they want you to get up right away. And this patient here with laminectomy, they have to be flat in the bed. They have to be flat for a couple of days in the bed. Your book says they have to learn how to eat flat in the bed. That's what the book says, so I have to go by that.
Are they gonna have a Foley in?
No. No, they're not going to have Foley. They will have Foley in for surgery. First thing in the morning, that Foley is out. But if they have a neurogenic bladder, you keep doing in and out, prior to discharging them, they still cannot pee on their own. Chances are they're going home with Foley. And if they're going home with Foley, you need to educate them on how to care for the Foley. You need to educate them that Foley is a sterile procedure, not to dislodge it. You need to educate them to measure their accurate intake and output. You need to educate them that Foley needs to be below the bladder, right? Educate them and their family. Those patients, most of them are younger people. So when they're going home, you may want to put a leg bag. How many of you have seen leg bag? Leg bag? Leg bag is like a small Foley. You don't want them to go home with the Foley bag like we have in the hospital. You disconnect it and put the leg bag and wrap it on their leg. They can wear their pants. I might even have Foley bag, you just don't know it. So it's something that's just underneath your pants. Nobody will see it. So they can go out to do things. But when they're sleeping at night, you encourage them to use the Foley bag because that bag gets full easy. So when they're sleeping at night, they may not know it's full. That's not the time to be cute. They need to put the Foley bag, so that they have a larger volume. Okay, you can take 10 minutes break. Too much moving around. Take 10 minutes break. Okay, let's continue. Any question with back surgery, laminectomy? Any questions? Okay, osteoporosis. Osteoporosis. What does the word osteo mean? Porous means what? Holes. So osteoporosis is bones with holes. That's what it is. Because those bones have holes, it predisposes the patient to fracture. So, what causes osteoporosis? Anybody? Age, medication, like steroids, like we discussed in previous classes, right? Decreased calcium intake, decreased vitamin D intake, increased phosphorus intake, thin build, smoking, alcohol. Osteoporosis is a metabolic disease. It is a metabolic issue. So if you can put that in your head, it's a metabolic issue that has to do with imbalance between osteoblast and osteoclast. Osteoblast with the B means building of bone. Osteoclast with the C is breakdown of bone. So there's imbalance between bone building and breakdown of bone. What is causing that? Those patients have decreased intake of calcium and decreased intake of vitamin D in their diet. Osteoporosis is mostly, which group have osteoporosis? Which are the females? Oh, that's another thing. Estrogen, decreased estrogen. Estrogen. Female have that. What kind of women? Which country or which group of people? Huh? Caucasian women, very thin build. So, and menopausal. Those people are very short, thin, fragile. They always look fragile. In the previous class, I had two of them sitting here. I'm like, you see a group that have that. I said, but be happy. Be happy because it's just all your God. The African American, we have the rest of the other diseases. How about that? We have the rest of the other one left. You have like 1%, we have 99.9. So osteoporosis, age. If you look at these contributing factors of osteoporosis, look at them as modifiable and non-modifiable factors. Because you cannot do anything about non-modifiable, but you can do something about modifiable. Can you do anything about age? So our intervention, we cannot do anything about age. And we sure cannot ask God why. So calcium intake. Yes. Calcium, they have to have 1,000 milligrams to 1 milligrams Q day. Vitamin D, 1,000 international units Q day. So those patients can supplement with calcium supplements. This is my little grocery store. This is calcium. This says 600 milligrams. This is my calcium. See, when you hit AARP, you have to be doing a lot of stuff to help yourself out. So this says 600 milligrams, international unit, IU. But the normal recommended dose of calcium is what? 1,000 milligrams to 1,200. So how many tablets do you think I need to take? 2 to make it 1,200. And that's what yes.
Your cardiologist, though, is going to say, be careful about calcium.
Okay. He said the cardiologist is going to say, be careful about calcium supplement. That's true, because you're giving them calcium channel blockers for those ones that have hypertension. You don't want to block calcium and be giving them calcium. But this time, we're talking about mobility, osteoporosis. Part of the problem with osteoporosis is lack of calcium. So they need to be taking calcium to supplement. So in this case, it's appropriate for the disease process that we're talking about. That again, why there's no universal anything about any patient. Every patient is unique. That's what I call patient-centered care. Every patient care is very unique to what is going on with that patient. So, medication. We talked about what? Steroids. That's one of the reasons when a patient is on steroid, you taper that down. You slow it down, and then wean the patient off. If those ones that have to use their steroid inhaler, well, then they have to use that over time. But the ones that take the tablets, they don't take it too long, they wean off of it, because it increases the chance of what? Osteoporosis. Remember, phosphorus and calcium. When you have increased phosphorus, you're going to have what? Decreased calcium. They kind of alternate itself. If you have too much phosphorus, you're going to have decreased calcium. You have too much calcium, you're going to have decreased phosphorus. In this case, you get that from diet drink. So you need to reduce your dietary intake, diet drink intake of, reduce that intake to prevent you from having too much phosphorus. I used to drink a lot of Diet Coke because I'm diabetic, thinking I'm doing myself a favor, but I'm really not. So now I try to substitute with water. They are team built. Can you do anything about that? No. Smoking and alcohol, can you do anything about that? Yes. You need to educate them on what? Smoking cessation. And how to stop their alcohol. Join the AAA, Anonymous, right? Alcohol Anonymous. Refer them to outreaches in the community so they can stop drinking. Estrogen, yes, the doctor might decide to give them estrogen replacement or not. That's up to the doctor to decide what they need to do. So you need to educate them, not only on taking the supplement calcium, they need to be able to know the food that contain calcium intake they can have. They need to have dairy products, beans, vegetables. Educate them on those things they can buy from the stores that can help them supplement. vitamin D, in as much as too much sunlight will cause skin cancer. But research shows if you go outside that first sun early in the morning when you first wake up and eat your breakfast out there for 15 minutes, that's the equivalent of the dose of vitamin D you need in a day. So educate the patient if they can eat outside early in the morning, not when the sun is hot, and burn themselves. That would be a good thing. Educate them to ambulate, and when they're outside, wear less clothes. Don't go out there with long sleeve, jacket, scarf, everything, where then you're not getting any vitamin D. Vitamin D is permeates through the skin, so your skin has to be exposed. So they need to wear short sleeve, maybe wear shorts so that their legs will be exposed so that they can get the benefit of vitamin D being outside. They can get that from bread, again, dairy or milk. You can get vitamin D from that. And then cereal. It's very important we educate them on the foods that they need to buy that can help them to supplement for the deficiency of these vitamins, because these things are in the stores. So these patients, again, that are immobile, I forgot to say that, again, incentive spirometer becomes important because of high risk of developing what? Atelectasis from not moving. They need to use the incentive spirometer and move. This patient, again, with osteoporosis, exercise. Part of our intervention becomes exercise. They need to bear weight. They need to walk, weight-bearing exercise. They need to walk. What is weight-bearing? Anybody? What is weight-bearing? Huh? Putting a weight on your ankle, not necessarily walking on your own. It's weight, like I'm standing right now, I'm putting my whole weight in my knee, my leg, lower extremity. That's weight bearing. My lower extremity is carrying my upper extremity. So that's weight bearing. I'm walking. So it's not just walking on your own. You might be walking with somebody holding hand. You're still weight bearing. You might be walking with the cane, weight bearing. You might be walking with walker, weight bearing. You might be walking with crutches, weight bearing. The lower extremity is holding the upper extremity while you're ambulating. Okay, again, let's start from this side. What have you learned so far? These three lines so far on this side. She said osteoporosis comes from thin build. I want you to be telling me about the patient like I'm telling it to you. You can't do nothing about thin build. Tell me what it's doing to the patient that we have to intervene.
Decrease the amount of diet drinks because of phosphorus levels.
They have an increase in phosphorus storage. Therefore, you need to educate them to decrease the amount of diet drinks they drink. What else? This side, these two lines, what have you learned so far? I don't want anybody have said before, somebody else. This line. It's caused by decreased calcium intake. Therefore, they need to take 1,000 milligrams to 1,200 milligrams a day. That's how I like that. Come on. These two lines, let's put it on the patient, just like I say it. Let's put it on the patient and then talk about the intervention. That's where it makes sense. I don't want to hear anything about thin bill. They need to avoid alcohol intake. So what do we do about that? And fire them to AA, Alcohol Anonymous, right? Okay, this last line. What else?
Medications like steroids, you have to wean them all because it's a risk factor for osteoporosis.
Medication like steroids, you have to wean them off because it's risk factor for osteoporosis. See how that goes, because that's how the test question goes. We have to put it on a patient, not isolate them. Yes. You raise your hand. Yeah, tell me something. Okay. She will take her patient early in the morning outside to get by 15 minutes so they can get vitamin D. Okay.
We can teach them to avoid uneven sidewalks.
Teach them to avoid uneven sidewalks. That's good. No, but that's good. Safety. Safety is really part of the safety. It's an intervention for them, yes.
They also want them to take the calcium on an empty stomach before they eat.
Okay. Take calcium on empty stomach before they eat. Okay. How many, what is the dose?
1,000 to 1,200 milligrams.
1,000 to 1,200 milligrams a day. Okay. That's good. I don't know you like that, but that's good to know. All right. So this patient's safety becomes an issue. Therefore, when they are in the hospital, these are the patients you have to put risk for fall in the bed. These are the patients you have to make sure that there's nothing plugged in the hallway that can make them trip. These are the patients you need to educate at home. Make sure they don't have carpet that's floating around, throw rugs, stuff that they can easily trip. This is the patient that when they shower, they need to put something in the tub to make sure they don't sleep inside their tub. Put like a carpet, not carpet, like something that will grip, plastic stuff that grips, so they don't slide and fall in the tub. So safety becomes an issue because these patients have what we call fallophobia. Fallophobia is one of the things I gave you to define. They have fear of fall. Because they have fear of fall, they know that when they fall, they're going to break their bones. There's no two ways about it. That makes them not to want to ambulate. That makes them not to want to walk or do things. So you need to educate them. Yes, you need to walk because walking helps to build bones. So you need to walk. And not only it helps to build bone, it helps to increase cardiac output, helps to increase production of oxygen. So you need to walk. Your body needs to walk. Because if you don't use it, you do what? You lose it. So they need to be able to walk. Just make sure that all those barriers in the way that will make them trip, you remove them. Osteoarthritis. What is osteoarthritis? What is osteo? Inflammation of the what? Bone, of the joints. Oh no, my leg is falling off. Let's make it a little straighter. So each bone has cartilage. Each joint of the body, whether it's finger or knee, mostly the knee. When you're talking about osteoarthritis, it affects mostly women, mostly in the knee or hip areas. It affects men too, but mostly women. Or it can be in the finger, in the joint area. Anywhere you have two bones joining together. It has cartilage. That's why when I'm walking down, I don't feel pain. That's why when you walk, you don't feel pain. You still have that cartilage that cushions the bones from touching each other. As the years progresses, you start overusing your knee because you have walked God knows how many million times you have used the joint. So those cartilages will start wearing off. So these cartilages will start wearing off. As it's wearing off, it's breaking. As it's breaking, it's falling down somewhere in between the areas of the joint where you have synovial fluid and stuff. As it starts breaking, it's going to start again pressing on the area that it has no business being, creating what? Pain. So this is what brings the patient to the hospital. Oh, I have this knee pain that won't go away. They start taking their NSAID, non-steroid anti-inflammatory. They start taking their pain medicine. They take Tylenol, they take ibuprofen. Nothing works. Because of this decrease in the cartilage now. So now you're going to have bone rubbing on bone. There's no more that cushion here that prevents that pain, the bone from rubbing. So again, it's caused by aging. It is caused by aging, overuse. So these patients have what we call overuse syndrome. Overuse syndrome. How many of you know Anthony Davis? What does Anthony Davis do? Basketball. Oh yeah. I be prepared, baby. So Anthony Davis have, which kind of surgery does he have? Which shoulder? Right? They say all the stuff in the TV. That's where I get them. So because of that overuse, he's using his right hand to shoot all the time. He's overusing that joint of the shoulder. That's why he has right shoulder problem. How many of you knows Drew Brees? Drew Brees? How many times have he had right shoulder surgery? Million times. Again, throwing football. Overuse. That's what is causing osteoarthritis. From constant movement, constant use of the joint, degenerates the joints. We work all our life. It catches up with you when you get older. By that time, you're already worn off all the cartilages. You have arthritis. That's why most elderly patients have arthritis. My mother keep calling me every day now. My pain won't go away. This is it. Mom, you 83. So, overuse syndrome. That's what arthritis, osteoarthritis is. So, you can't do nothing about age, but you can educate them to what? Exercise. Again, heat and cold, similar to what we did, heat and cold. These patients swimming. This is the only book that says that patients that have arthritis can do light walking. This year, third edition, is the first time I'm hearing osteoarthritis, light walking. It's usually, they say, non-weight bearing. But this book says light walking. So we're going to go by light walking. I don't know what is light and what is strong walking, but that's what the book says. So light walking. But for osteoarthritis, they have to really walk. They have to do a walk. Either they walk with the cane, it doesn't matter. They have to do weight bearing. Because when you are doing weight bearing, you developing more bones. You're making your bones stronger. You're extracting those calcium that the body needs, the bone needs to grow. So weight bearing improves bone osteoblast. It increases that bone density. So they need to walk to be able to generate that. But in osteoarthritis, light walking. Because they have pain, remember it's bone, rubbing on bone, it hurts. Those patients, when they sleep at night, they wake up in the morning, they can't move. They have severe pain. It gets stiff on them. So once they start walking again, guess what happens? The pain goes away a little bit. Why do you think the pain reduces when they walk? What is the body doing at that time when you're walking? Increasing what? Blood flow. You're walking, increasing blood flow, brings oxygen and nutrients to that area. It'll be less painful. But then if you walk too much, again, you have pain. So that's why it's very cyclic. So walk with them, educate them to still exercise. It's better to walk. Because if you don't use it, you do what? You lose it. So light walking, swimming, bicycling, stuff that they don't have to use that joint a lot, helps with those patients that have osteoarthritis. Give them their pain medicine, of course. Any questions? Okay. Elements of musculoskeletal assessment, past medical history, get the patient history. Look at their tribe or where they came from, their daily activities, what they do, their social status, if they're drinking or not drinking, do they exercise or not exercise. They're going to have pain, reduced joint movement once they have those pains. They're not going to be able to move around. Falls can contribute to that. Fatigue can also contribute to that. They're going to be fatigued. They haven't been able to exercise. They haven't been able to move. Always remember, when we say exercise, we don't mean like running marathon. We just mean something as simple as walking outside the hallway of your house, going outside to pick up newspaper. Just go by your neighbor yard and stop and talk with them. Little things like that. Daily activity. Altered gait and imbalance. They're going to have altered gait because of the pain they're having. They're not going to be able to move normally, but it's still okay. Let them still ambulate. They have reduced function Because they have pain, they're not going to be able to move like they normally will. Diagnostic tests, we're not going to be able to know all these diagnostic tests, but bone scan is another one that's very good because that tells the doctor, what's going on in the bone. Arthroscopy is where they do with the arthritis. They scope to see what's going on with those joints. Those are the most common ones. And then bone density tells you about osteoarthritis. How much bone, how much porous, how is the bone density? Yeah, do they have severe osteoporosis or not? Prevention, regular exercise is number one. They all need to exercise. You need to educate them to exercise. Whether they have osteoporosis, osteoarthritis, or back pain, they have to exercise. Exercise helps to prevent back pain, so they need to exercise. Protect against injury. We talked about osteoporosis, or even all of them. Prevent patients from injury. Make sure there's nothing they can trip and fall. If they are spilled on the floor, we have to mop it. Make sure there's nothing that will make them trip or fall. Of course, for preventive measures, put that sign on the board and follow it up. Make sure their call light is within reach. All that good stuff. Collaborative intervention, you cannot do that by yourself. Frequent turning. We have to turn that patient every 2 hours. The word frequent turning doesn't tell me anything. We have to turn patient Q2 hours. We have to put a number to it so that it be objective. Frequent don't mean a thing. Frequent turning, you don't know if it's every 12 hours. So we have to make sure we turn the patient every 2. Position, align the patient. Aligning the patient depends on what's going on with the patient. They have laminectomy, align the body. Lock roll the patient, upper and lower extremity at the same time. Put the head of the bed low. Patient needs to lay flat in the bed for a couple of days to allow the incision, the fusion, or laminectomy to fuse, to work. Range of motion could be passive or active. Range of motion is better than nothing. If that patient cannot move by themselves, somebody needs to be doing the range of motion for them. That becomes passive, right? If they can move, let them do it themselves. It's more important for them to do it themselves, so it becomes active range of motion. But if they cannot, well, then we do it for them on physical therapy. Weight bearing, if possible. Weight bearing will help to build bone, especially with patients with osteoporosis. It's important that they walk. It doesn't matter whether they're walking with a cane or they're walking with a walker. It is still weight bearing. The lower extremity is still carrying the upper extremity. That is very important. So it helps in building bone. Measure to optimize elimination. Those patients, because they are in the bed, it decreases GI motility. That's why everybody in the hospital gets protonics. Everybody gets coles for stool. Everybody gets protonics. Because when you are in the bed, you're not moving, the body makes more acid, predisposes the patient to acid reflux, and then they're not going to want to eat. So you give them protonics to help with that. Sometimes you give them Pepsi, depending on what the doctor wants. So everybody that gets protonics doesn't mean they have GERD. I always hear my students say, oh, because I'm giving you protonics for your GERD. They don't have that. Gastroesophageal reflux disease, they don't have that. Not all of them have it. We're giving it to them because of that increase in acid production by the body, because the body is stressed out from you being sick, to suppress that. Nutrition, of course, we discussed about nutrition. It can't be no better than this. I showed you everything. The type of diet with vitamin D, where they can get that cereal and bread. I showed you for that calcium. They can get it from vegetables, beans, and milk, or dairy products. So we have to remember all these. We have to remember again how to use the incentive spirometer. We're talking about mobility. These patients have high risk for developing atelectasis because they're not moving. Educate them on how to use incentive spirometer. The same way we learned it in oxygenation is the same way you use it. The same thing. Exercise, ambulation, any question here? We already discussed all these. Surgery can be curative or palliative. Somebody says some people have back surgery, it doesn't heal. It can be palliative. Instead of their pain being 10, it might reduce to 8. So it's better than not doing anything at all. Or it can be curative. Some people do get well after that. It's getting much better though. Immobilizer to stabilize those areas. It could be cast, it could be brace. Some people will break their arm or have a little inflammation. The doctor might say put it on sling. So all those things are to immobilize the area, prevent pain, and give the area time to heal. That forces you not to use it so that it gives it time to heal. Assistive devices, crutches, canes, we talked about all those already. Preventive measure. Any questions? Ergonomics. Ergonomics are those devices that companies make to help you to perform something better. Like just the act of raising the bed up is an ergonomics. It's meant for a reason. I used to raise the bed up for the student. I started telling the student, raise the bed up. Then I realized they don't know which button to press. Raising the bed up is always on outside the bed because it's intentionally done. They don't want it inside. They don't want the patient raising themselves up and down. They're going to fall. So it's outside. So it's going to be two buttons. One, arrow up, arrow down. That means bed up or down. If you have 4 buttons, that means head up or feet down. Press the one that have 2, up or down. It's always outside the bed. It will never be inside the bed. So those are ergonomics. Or you see people who are typing something, they wear something to prevent their finger from having carpal tunnel syndrome. That's ergonomics. Or you typing, you have a mat that have a little thing where you rest your wrist and then you type it. That's ergonomics because what it's doing is it's preventing you from bending this wrist. You're bending just the finger. That's ergonomics. So anything that helps you to align your body, prevent injury, causing osteoarthritis, is an ergonomics. Positioning, drugs, heat, we talked about all this already. Minimal invasive procedure, it is minimal because they have like puncture sites. It's not a major surgery. I focus on laminectomy because it's conventional open surgery and because it's the most commonly done one. We're not going to know about all the surgeries on earth, but laminectomy is done most often. So that's why I focus on that. It's an open surgery. That means they're going to have scar, high risk for infection, high risk for bleeding. Again, high risk for nerve damage. So we have to pay attention to those. Watch your patient intake and output. Make sure they're avoiding. Assess their neuro status because it's neurosurgery. Post-operative care is the same post-operative care for any patient that have any kind of surgery. The only major difference is CSF check. You have to assess that fluid that's leaking to see the color. So what color will tell you CSF? White. If it's clear white, what's the first thing you do with that? Call the doctor because you cannot fix that. But if it's red, what will you do? Well, I don't want you to feel like red is normal all the time because if they're gushing out blood, okay. If it's little blood, just reinforce it. But if it's just gushing out, you reinforce it, but still call the doctor. Yeah. So don't kind of rule that out that you don't call the doctor. But if it's gushing, reinforce first, then call the doctor. CSF, call the doctor first, then you reinforce. You see the difference? Okay. Because you can't do nothing about CSF. Patient positioning and mobility, educate them on moving. Home care management, again, make sure that at home they don't have carpet that they threw away. One time I went with a friend to her mother's house. They have nice sofa, covered with plastic. Then they have nice carpet. Again, they have this plastic that runs from the door all the way to the room, and that's the only place you step on. I'm like, really? What is the essence of buying sofa if nobody can sit on it? What is the essence of having this nice carpet? Nobody steps on it. So those are the things that are high risk for patients to trip as they get older. Some of these things are good when you're young, but when you get older, when we were trying to buy a house, me and my husband, we swore we don't want story building. Because as we get older, we're not going to be able to climb those nice story buildings. But nobody thinks about that. Oh, we want big house. We want to show off we have money. Oh, Lord. Then here comes arthritis. You can barely get step from outside to inside, not to talk about climbing upstairs. You start making adjustments how you're going to bring everything down. Nobody thinks about these things, but they come. So, arrange the house. Educate the patient on what to do at home. No throw away towel. Make sure they put a mat in their bathtub so they don't sleep. Anything that will trip them on the way when they get home, to avoid those things, remove them. Community resources. Osteoarthritis is a degenerative joint disease. It's slowly progressing because it catches up with you as you get older. It's slowly progressing because of the wear and tear, So DJ, the degenerative joint disease, it degenerates and joint, of the joint. Slow progressive. Age, gender, obesity is a factor because the more obese you are, the more you put in pressure in the joint area, the more cartilage you wear out. So those people that are obese get arthritis younger in age than somebody who is not. Trauma can cause that. Mechanical stress, shooting the ball is mechanical stress to the joint. Or somebody who works in car assembly. If they're working in the car assembly, maybe your role is to put the door. So all day, when it comes to you, you put door. It goes. Another one comes, put door. You're going to do this all day. All day. You don't realize how much time you're using your joint. So repetitive activity predisposes you to that. Skeletal deformity and drugs. We talked about that already. Joint pain, they're going to have pain. They're going to have increased disability of joint. They're not going to be able to get up and move around because of pain. They're going to have crepitus. What is crepitus? Bone rubbing on bones is crepitus. Deformity, because they're not going to be able to move. Part of those joints become stiff because they're not using them. You don't use them, you lose them. You lose function of that part of the joint. There's bone enlargement in some of the joints. Non-pharmacological care, joint immobilizer, moderate exercise. We have discussed all this already. Thermal modality is heat and cold. Thermal, temperature, thermal. Heat or cold. Environment safety, I just went over all that already again. Educate the patient on their disease process and what they need to do about them. Medication, Tylenol again. Q8 hours, not a C3 grams, 1,000 milligrams every 8. Topical, capsaicin. Capsaicin is made with pepper, cayenne pepper. Cayenne pepper is an anti-inflammatory. I told my mom, put some more pepper in your food. I don't know what else to do. Just put a lot of pepper. She already likes what we call pepper soup. Okay, then add more soup, more pepper. Aspirin. NSAID. Again, you have to watch for bleeding. Educate the patient on the risk for bleeding for those medications and how to take them. NSAID they have to take with food because of GI what? Ulcer. Intra-articular injection, the doctors give them steroids via the joints. We don't do that, the doctors do that. The patients say it helps a lot because it's a lot of inflammation in those joints. But it doesn't last forever. It wears off and then they complain again.
So what type of injection that they give, like every 6 months or once a year?
It depends. Sometimes they do it like that, sometimes they don't. But I've seen somebody get it once every 6 months, my coworker.
My mom takes one by month. She takes it every month, and she has to set it up for an hour to 2 hours. But it's a pill.
Oh, that's very good.
That's the one for, yeah, that's the osteoporosis.
Oh, Fosamax.
Yeah.
Okay. Osteoporosis, chronic metabolic disorder, older age. Do I have to explain anything here? This is the test to diagnose the porosis. Patient teaching, begin osteoporosis teaching in the age 30s. Focus on teaching because it has to do with lifetime of diet. It's a metabolic disease. Drug therapy given for osteoporosis is what? Fosamax. You give them Fosamax. Because this Fosamax is poorly absorbed in the GI, you have to be taken on empty stomach. It has to be taken on empty stomach because of its poor absorption on the GI. Osteoarthritis and osteoporosis comparison. Osteoarthritis, mechanical stress, repetitive activity that causes that. Physical activity like sports, people who throw ball or kick ball, footballers too. Exercise, Non-weight bearing, like I say, this is the only book that says that they can have light walking. So we say light walking. They also can have cycling and swimming. Osteoporosis, you have to have weight bearing because it helps to build up the bone. Walking, hiking, dancing, and stair climbing. Any questions? Any questions? All right.